This is Konstantinos Adjapanias, who will be presenting a case of 5-ALA fluorescence-guided surgery of a high-grade glioma. The patient is a 50-year-old right-handed male who presented with progressive headaches and left-sided weakness. On preoperative imaging, there was evidence of a contrast-enhancing intraaxial mass involving the right parietal lobe, causing vasogenic edema and cerebral compression. The lesion did displace the central sulcus on the right, accounting for the patient's contralateral left-sided weakness. The patient had consented to proceed forward with surgery for debulking of the tumor and a tissue diagnosis period. The patient also consented to proceed forward with 5-ALA fluorescence-guided surgery. The patient was administered 5-ALA 4 to 5 hours prior to surgery. He did receive a 20 milligram per kilogram dose orally. The patient was taken to the operating room where he was positioned supine with the head turned to the left for a right parietal craniotomy. The head was placed in 3-pin Mayfield fixation and neuronavigation was used. Both cortical and subcortical motor mapping were performed during the surgery with positive identification of the motor pathways anterior to the tumor. 5-ALA fluorescence-guided surgery was performed in combination with conventional microsurgery. This video highlights the initial visualization of 5-ALA tumor fluorescence after switching on the blue light filter. The tumor is readily apparent through the peel surface as a violet-red color fluorescence. Resection was carried forward, debulking the tumor. As the infiltrative tumor margin was approached, a more pink color was encountered. You can see during the surgery that debulking of the pink eventually resulted in visualization of less and less fluorescence along the tumor margin, permitting maximal safe resection of the tumor in combination with cortical and subcortical mapping. Postoperative imaging confirmed a gross total resection of the tumor with no evidence of residual contrast enhancement after the resection. The patient recovered quickly after surgery with no motor deficits. Histopathology revealed a glioblastoma tumor, and molecular markers revealed no MGMT methylation, and the tumor was IDH1 wild type. The patient completed chemoradiation and concurrent temozolomide. He did develop a contralateral left parietal recurrence that required a second craniotomy over 4 months after his first surgery. He is currently on Avastin chemotherapy and is doing well 11 months after initial presentation.